Assalamu alaikum wa rahmatullahi wa barakatuh. Welcome everyone. Thank you for joining us for today's webinar. اتفضل دكتور خالد.
Assalamu alaikum wa rahmatullah, dear colleagues. Today we are happy that we have a lecture from Dr. Ragab Zahrani. He's an associate professor in Al-Ba University Medical College, and he is a consultant in Saudi German Hospital Group. Today he will give us a talk about head and neck oncoendocrine services. Are we ready to start? Please welcome Dr. Rajab.
Thank you so much, Khalid, Tamer, everyone. Thank you for this opportunity for the German Hospital Group. And with me, the eminent head and neck surgeon, Dr. Jaber Al-Harbi, actually is the actual future of the services. We are actually starting the service, and I'm really enthusiastic, and I hope we can serve and start in very good head and neck services of the German Hospital Riyadh branch. We have actually 2 clinics per week receiving the head and neck cases, and monthly I'll be visiting the Riyadh branch. When we talk about the conflict of interest in the head and neck or in private hospitals, it's a very difficult to say we don't have a conflict of interest, because we already everybody know that we are a private sector. So usually the financial part of the head and neck services in the private sectors is at play. I will not say the only factor, but it is important factor. You know, the different head and neck cases, usually it's not well understood by most of the colleagues because of the maybe the new concept. That's why we are giving the courses and lectures here, and honestly, we are moving from the big, devastating, destructive procedures to go to least and minimally invasive with the new technology. As example, actually in head and neck, doing the silent endoscopy courses, the sleep surgery courses, and beside the actual head and neck courses. Usually, me and the other colleagues, including Dr. Jaber, we found actually this course, and we started to do it, and it became very popularized, even in the Saudi board. Now, one of the courses that's recognized, and for the senior resident to teach actually the new generations basics and the standard procedures. When we start to have a head and neck services, especially in as a new, it should be organized, and we should talk a common language between each other. I was very happy really for somebody like Dr. Jaber to join us, because in head and neck services, you need a manpower and you need cornerstones. And I think the cornerstones is the head and neck surgical oncology. I mean by head and neck surgical oncologist that he completed the work and he have at least from 1 to 2 years or 3 years subspecialty concentrating only in head and neck. And this is what Dr. Jaber and me also, we did that. After we finishing our board, we concentrate 1 or 2 years, up to 3 years, only doing head and neck cases. So our main job, our main target of patient are the head and neck surfaces. But we need to start excellent service to talk a common scientific language between the different specialties. And as an example, the scientific language between us and the endocrinologist and also the pathologist. We need to talk a very simple and a common scientific language. So and also radiologists. So we treat the single patient in a very organized units. That's why what we're trying to do in a few visits and months later. We'll set the regulations, we'll talk to other colleagues. And as I said, the cornerstone is empower the head and neck surfaces. And I'll give Dr. Jaber the floor to talk about different cases that we plan to do it. Actually, we are concentrating, we have an idea to make it a center of excellency in the thyroid and a parotid or salivary gland hospital among the central region or Riyadh especially. And I'll give the chance to Dr. Jaber to give us the major diseases or major subjects that we will do in our visits or in our head and neck surgery. Please, Dr. Jaber.
Thank you, Rajab, for the comments and the introduction. As head and neck, we are very proud that we joined the Saudi German hospital. I think it's one of the biggest private hospital that covers most of the regions in the country. So to have a head and neck center that help different region, this is a very good service that help especially in the Saudi Vision 2030. So we as a team, ENT department, with the help of other colleagues, even in other regions like Dr. Rajab, we are planning to build a teamwork that help our patient and provide best practices to our patient and best patient experience. So we, with our colleagues in radiology and pathology, endocrine, patient services, nurses, so we have to speak a common language, as Dr. Rajab said. So with radiologists, we speak the American Academy of Radiology. They have thyroid imaging reporting and data system. We call it TIRADS. So they have TIRAD categories. So our language is the same. With the lab, we follow the American Thyroid Association in all of our practices. For the histopathology, we follow the Bethesda classification. So when we come to thyroidologist, we report for thyroid. After the describe the ultrasound, at the end they will put the category of the thyroid. So depending on the thyroid, to do the patient. So thyroid 1 is totally benign, while 5 and 6 is mostly malignant. For the when we ask for FNA, pathologists usually they give a grading system to the fine needle aspiration, either non-diagnostic to malignant. So we speak the same language. So after doing the ultrasound, labs, and fine needle aspiration, we usually stage the patient according to American Joint Commission of Cancer, the 8th edition, which updated like 1 year ago. So in general, thyroid, even malignant, it's 99.9 is the prognosis is very excellent. So the thyroid disease is very common. It's estimated the second cancer after breast cancer, and the incidence will increase with the time with the increase of the radiological investigations. So usually patients present to us in different stages, like this huge thyroids with airway compromise, with difficulty swallowing. And as I said, differentiated thyroid cancer, even with this striking picture, the prognosis is very excellent. So we usually, we have a policy and protocol that we follow. Usually we start with history, examination, investigation, including laboratory radiology. If we have like these big thyroids, we usually ask for CT scans so we can see the extension, lymph nodes, affection to the airway, invasion to surrounding structures. If you see, this is huge thyroid that affects the airway. There is a narrowing in the airway that has to be kept in mind. So when we come intraoperative techniques, we are planning to have intraoperative neuromonitoring that we continuously monitoring the recurrent laryngeal nerve, which is a very fine and delicate nerve that we commonly encounter in thyroid surgery. So thyroid surgery all about the recurrent laryngeal nerve. Thyroid surgery without taking care of the nerve is nothing. So we are planning to have the neuromonitoring machine hopefully in the near future. Nowadays we are doing the intermittent nerve stimulation where we identify the nerve, we stimulate the nerve, that we make sure that the nerve is totally functioning. So this the specimen after we remove the big thyroids. The incision, usually the incision is from 4 to 6 centimeter. This is the average incision, but when we have big tumors, we have to extend the incision. And usually we do it in subcuticular fashion, but this patient, because it was combined with neck dissection, it was closed by staples. In few patients, the thyroid become very invasive. As you see here, it's invading the skin, where in very long standing thyroid, or sometimes anaplastic thyroid, they present in a bad look. So as I said, we are following the American Thyroid Associations. We are working in a team. Some patients, they need genetic testing, especially those with medullary thyroid cancer. Endocrinologists are our great friends. They are the one who usually refer the cases to us. They are the one who follow the patient after surgery, and nuclear medicine or nuclear radiology, usually post-surgery for differentiated thyroid cancer. Some patients, they may need radioactive iodines and total body scans. So as you see, we are working in a team. So we have some challenges in surgery. Usually in advanced stage thyroid cancer, usually we do central neck dissection even if there is no lymph nodes. But central neck has many important structures. We have the trachea, the larynx, the pharynx, the esophagus, and the most importantly is the recurrent laryngeal nerve. Some patients, they present with lateral lymph nodes, where we encounter the carotid, the internal jag, the vagus nerve, and the sternocleidomastoid muscle. Even some patients, they have retrosternal extension or missed to the mediastinal lymph nodes, where we need the help of our thoracic surgeons. So this is the difference. If you see, this is the trachea, the internal carotid artery. Sometimes we have invasion to the trachea that we have to close it. So as well as we need, sometimes we have life-threatening events that need ICU, huge masses that need awake intubations with high-risk operations. Sometime when we have a very bad disease that involve both recurrent laryngeal nerve, we need a tracheostomy. But with the help of intraoperative neuromonitoring, this complication is less likely nowadays. So the team is the secret. So we need multimodality and multi-speciality. A team is not it's not a one-man show. So treatment of differentiated cancer is surgery. So post-op salvage almost needed. Sometimes we need reconstruction, especially in those with invasion to the skin. The recurrence rate, if treated, is not high actually. But those with the bad disease, not completely removed, they have high rate of recurrence. High rate of tracheostomy, this is usually for squamous cell carcinomas. Now we'll shift to the friend of the thyroid, or the neighbor of the thyroid, which is the parathyroid. So usually these patients referred from our colleagues in nephrology when they have a patient with renal failure, those in long-standing hemodialysis, they have refractory hyperparathyroidism. So usually they have sky-high parathyroid with very high calcium and phosphate. Usually these patients, the parathyroid more than 800, they have hypercalcemia more than 2.5 millimoles, they have bone disease, sometimes they have extensive extraskeletal calcification or calciphylaxis, pruritus, unexplained myopathy. So if you see the deposition of calcium in the skeletal muscles, usually these patients, we remove all the 4 parathyroid glands, and usually post-operatively they develop hungry bone syndrome, where they have severe hypocalcemia and severe hypoparathyroidism. That's why the team is the secret. We ask usually the help of our medical people, our endocrinologists and nephrologists as well. Now we move to the second part of our webinar, which is the parotid. So the parotid is located just anterior to the ear, over the ramus of the mandible. So this is the patient presented with long-standing parotid lesion. Usually parotid neoplasm is very few, it's not that common. But because we are covering the whole country, we see these cases frequently. So the parotid surgery is a surgery of facial nerve. All of you know that the facial nerve is immersed run in between the superficial and the deep lobe of the parotid. So the parotid surgery is the parotid of facial nerve. As we say, thyroid surgery is surgery of recurrent. Parotid surgery is the surgery of facial nerve. And usually we identify the main trunk, the terminal branches of the facial nerve, where you can see it in the intraoperative pictures. So it's a count about just 0.5% of all head and neck neoplasm. Fortunately enough, the 80% of these lesions are benign. But keep in mind, all parotid neoplasm has to be removed surgically, okay? Even benign ones, for a lot of consideration. But just keep it a rule, all parotid and salivary lesions has to come out, whatever the pathology. Sometimes we have the parapharyngeal extension of the deep lobe of parotid, okay? And these cases are a bit challenging because of the access of the parapharyngeal space. But usually these cases are very benign. And although the access is difficult, but most of the surgery goes very smooth. So in the parapharyngeal space, we have peristyloid and post-styloid. Polymorphic adenoma of the parotid is the most common, where they present with like a glass hour appearance or dumbbell tumor. We have other differential like neurogenic tumors, paragangliomas. As I said, most of the tumors are benign. Surgery is the mainstay of treatment. The other challenge of head and neck tumors when they present in the kids. So although it's a very rare, but we could see it every now and then. And we have good experience doing thyroid and parotid and head and neck tumors in the pediatric age group. So all this is intraoperative pictures of some of our patients. Sometimes we have unfortunate patients when they present with rare advanced tumors, like this patient have multiple sites of melanomas, where we have to involve the medical oncology colleagues, radiation oncology colleagues, and as a role, we have to discuss these cases in the tumor board. So head and neck surfaces, from hospital and institute point of view, the knowledge is the power. So when our colleagues in all departments know that we already have head and neck surface, so they are starting to refer these cases to us, so we could help these patients, and we can play our role as a team member of the whole institute. So we are better together. This is very important. We are together. No matter whatever we feel, and what really matter. So we have to give the best to our patients. We have to give our colleagues their importance. So from patient side, patient should be approached as a team, not individual. You see, I'm stressing on this because this is, as I told, this is the secret. So bring the best care under one roof and their home. So we could help every patient in every branch of Saudi German hospital all over the country. So I hope to work together for the best interest of our patients. And here I conclude the lecture. I hope it was light and up to the point. And thank you.
So much, Dr. Jabir. Just a few words before we shift to the questions. As everybody see in the lectures, we are trying to view what we can do actually in the head and neck services. The bread and butter of head and neck is the thyroid and neck masses or neck lymph node. My advice actually to my colleagues, to especially the general surgeon and the other endocrinologists, that they did a thyroid actually. I always say this point to this specific point to my colleagues in thyroid in the general surgeon. I know that most of the general surgeons, they are doing the thyroid. Believe me, we are not in a competition. We are not contradicting each other at all. We are a cooperative, our colleagues from all services, even the general surgeon. We know that the general surgeon, they have a subspecialty called endocrine and breast. And with time, the same obstacles we see every time. Is it going to the general surgeon or no, head and neck or endocrine? Honestly, even my subspecialty, I spent 1 year only doing thyroid and parathyroid. Although I don't mind at all to be done by the general surgeon and to be cooperated with them and to help them. especially if it goes to the lateral neck, or central neck, or lower down in the mediastinum. As Dr. Jabir said, maybe in the difficulty we face. Sometimes we face a difficult case that we need a vascular surgeon, we need a thoracic surgeon, we need sometimes reconstructive surgeon with us. Our message actually today is considering on this point that we are planning to help and to start by Riyadh branch to optimize the head and neck services and to build up this service stone by stone, bit by bit. We reach to the standard care of management in head and neck, which is sometimes lacking. Actually, the Riyadh city, Jeddah city, and now starting at the MAM. Yes, we are we established it long time. I know that, but in the private sectors, believe it or not, till now is not a standard, and that's why we need to work on this. We talk in a common scientific languages between different specialty, and the benefits, it will go directly to the patient, and believe me, it will goes even financially to the place, because if you are known as a department or as a place that you are doing a very good services and excellent outcome. I think this is the best advertisement, is the word of mouth. The bread and butter of head and neck is the thyroid. The parotid, actually, it's by default going to the head and neck, and not everybody like it because of the facial nerve, as you know. Usually, it's very rare complication in the hand of the trained head and neck. As Dr. Jabir said, fortunately, it's 20% only cancer. But if it's cancer, I don't think no one can deal with the oncology in the especially parotid area except the trained head and neck oncologist. The other diseases, the aerodigestive tract, the other head and neck oncology, also I think it's part of our services, which is day by day became more popular and everybody knows. The last thing actually I want to stress on it, that's the cervical lymph nodes. My advice to my colleagues from other specialties, especially from other surgeons, if you find a cervical node, you like to treat patients carefully, don't go to open the nodes without referring this patient to ENT, any general ENT, not be hidden in service. No, it should be examined by ENT. An ENT will immediately examine the aerodigestive tract, especially the nasopharynx, which is very common cancer in Saudi Arabia, the oropharyngeal cancer also. And it will be detected by the head and neck, so it will spare the patient to open the neck in very rare disease. And sometimes, yes, I believe it's not optimum, and we should not open the neck if we find the primary tumors in the nasopharynx or nose or aerodigestive tract. I hope actually that our endocrinologist, nephrologist, radiologist, histopathologist, nuclear medicine to establish in one day a head and neck combined clinic that we can even, we'll start by every 1 month, every 2 months, and we'll improve our services. And thank you for everybody to listen to us. And we hope we'll meet together, inshallah, for more specific and scientific event. Thank you so much.
Thank you very much, Dr. Gaber, for this very simple but informative lecture. And thank you, Dr. Ragab, of being with us. There is actually some questions in this regard about the subject. For example, one said, "Good evening. I am diagnosed with PTC 2 years ago. What is the prognosis of PTC and what is your best management for PTC? Thank you.
The diagnosis of papillary thyroid cancer.
Papillary thyroid carcinoma. Yes.
Yeah, PTC is a papillary thyroid cancer. The prognosis is excellent. Actually, one of the best cancers. And the best management of papillary thyroid cancer is surgical excision, of course. And according to the size, according to the scan, we may add ablation, as mentioned in the lecture. But the prognosis is excellent. We are talking in usual cancers, sometimes 2 years in larynx or hypopharynx. We increase it 5 years in the nasopharynx, 10 years. Now in thyroid surgery, we are talking about 20 years survival. So PTC by time and with the excellent surgery, I think we are talking about excellent prognosis cancers. So I don't think you need to worry about it. You follow it very carefully. I think the prognosis is outstanding. Thank you.
Thank you, Dr. Rajab. She is asking, she was diagnosed with papillary thyroid cancer. So what I recommend, there is a lot of details. In generally, as Dr. Rajab said, the prognosis is very excellent. It's not excellent, it's very excellent. Sometimes we consider it as a benign disease, not malignant. But there is a lot of details, depending on the type of the pathology, the subtype of papillary thyroid cancer, the size, the presence of lymph nodes, the age, the complete resection of the tumor, and the need, there is a possible need for radioactive iodine. So what we recommend is you have to follow with your with the specialized endocrinologist who will guide you to the best practice for yourself. Thank you.
Actually, I am the one who has the question for Dr. Jaber. Dr. Jaber, there is a lot of surgical approach for the parapharyngeal space. Do you prefer a certain approach, or it's according to the case and the findings? Do you prefer mandibular, for example, mandibular resection? Do you prefer
usually the parapharyngeal is the location of project space is a bit difficult. So if you speak by the books, there's a lot of approaches, but the one depends on the tumor, depends on the extent of the tumor. What usually we do, it's transcervical through the neck. Sometimes we have to transport it. Okay. Very rarely we go transmandibular. So most of the time, it's a deep lobe parotid, polymorphic adenoma. So it could be resected easily transcervical. Sometimes we need transported. But if you go by the book, is mandibular split. I've never did a parapharyngeal space that needs a mandibular split.
Thank you.
Thank you so much, Dr. Rajab and Dr. Gaber, for the interesting presentation. Thank you so much, Dr. Khalid. Thank you, everyone, for joining us. See you next week, inshallah, at the same time. Assalamu alaikum wa rahmatullahi wa barakatuh.